Good evening, everybody. My name is Luca Segantini. I am the ESOT CEO, and I'm very glad to welcome you all to this webinar on the COVID-19 pandemic and the lessons we have learned from the Italian situation. We have a distinguished panel of presenters tonight, and I'm very happy to introduce the two chairs for tonight, who are Dr. Bellini from Belfast, UK, and Dr. Potena from Bologna, Italy. Luciano, Irene, over to you.
Thank you, Luca, and good afternoon and good evening to everyone, and thank you all for finding time and joining today's webinar. I am a renal transplant surgeon at Belfast City Hospital in the UK, and I am also the Transplant Live coordinator. The COVID-19 pandemic has represented a game changer for the field of organ transplantation, and since we learn day by day from this unprecedented challenge, we aim to stay up to date and offer the latest research and findings via social media. I warmly invite you, therefore, to explore our Transplant Live websites that are on www.esottransplantlive.org and on www.esottransplantlive.org, where you could access 24/7 this webinar series kindly developed with an unrestricted grant from Chiesi, and you could also contribute your own experience, interact and collaborate beyond your institution reach. Last time we focused on the lockdown ease, and today it is time for a first balance, as it represents the reopening of the Schengen area for international travels among the European states members. So we could see what this pandemic has represented during the lockdown. Italy was the very first European country that was hit by this pandemic. So our top lineup of speakers will give really an up-to-date and first balance of what this COVID-19 has represented. But without any further delay, I would like to leave the floor to my co-chair, Luciano Potena, Medical Director of Heart Transplant, LVAD and Heart Failure Program at Bologna University Hospital, Italy. Luciano, over to you.
Thank you, Irene. Thank you very much. And good afternoon and good evening, everyone, for being here today with us. I also would like to acknowledge the unrestricted grant from Chiesi, who sponsored this event, and it's my great pleasure to introduce you the outstanding roster of speakers tonight. We are going to listen Professor Andrea Crisanti, who is the director of the Department of Molecular Medicine at the University of Padova in Italy. Dr. Massimo Cardillo, who is the General Director of the Centro Nazionale Trapianti, who is the main transplant coordination and the main agency coordinating all heart transplant, solid organ transplantation in Italy. Then we have Professor Umberto Maggiore, who is the head of the transplant unit of nephrology of the University Hospital in Parma, Italy, and Professor Patrizia Burra, who is the chief of the multivisceral transplant unit, again, University Hospital of Padua in Italy. It's now my pleasure to introduce and to leave the word to Professor Crisanti, who is going to talk us about the COVID-19 transmission dynamic, the lesson from Vo municipality. Thank you.
Okay. Thank you very much for the invitation. It gives me the opportunity to share with you what we have learned during the first week of the epidemic in Italy, and how what we learned has been used to implement what we believe has been, given the situation, an effective approach to control the disease. So if I can have the first slide. Well, I don't have a conflict of interest. Well, this shows where this municipality of Vo is in the province of Padova. And the night of the 22nd of February, a patient from Vo died in the hospital of Schiavonia. The swab was carried out post-mortem and disclosed the presence of the virus. On the day after, the local authority imposed a quarantine on the entire city, so nobody could enter and nobody could get out of the city. When we realized this, we contacted immediately the regional authority, explained them that they created a unique epidemiological situation, and we want to test this the all people living in Bo a second time. So they were first tested on the, I don't know if you can see the slide, but this shows exactly the testing. In principle, there were 3,270 residents on the 22nd and 27th of February. 2,800 individuals were tested. 2,739 were negative, and 2.6% were positive. Now, this was already a very high percentage that, on the light of what I will explain you later, shows what happened in Lombardy. Now, on the second survey, we tested 2,343 individuals. 29 were positive, 2,314 were negative. Of these 29, 21 were confirmed cases, so they were already positive on the first occasion. And then we have new cases, 8 new cases. Now, this is the timeline. Sorry, if you can go back. This is the timeline, and this is the first screening, the second screening, and so on. So if you can now go to the next slide, this summarizes more in detail what we found. So this is the number of individuals that have been analyzed in the first and in the second survey, and this is the prevalence of COVID-19. So it goes from 0.26% to 1.2. But now, what you see here, it's already very interesting. Now, this is the positive on the first survey, this is the positive on the second survey, and these are the new cases. Now, as you can see, there were only 8 new cases. So in principle, the lockdown dramatically reduced the transmission of the disease, about 98%, and we will see this in a moment in a model, how effective this was. So if I can have the next slides. Now, this is a slide that shows the distribution of positive individual arranged for sex and age. Now, here you can see, for example, that we have 43 males and 30 female. Although there is a little bias for males, they are not statistically different. However, on the second survey, we see 20 female and 20 male and 9 female, and this difference is statistically significant. What does it mean? It means that in the meanwhile, more female were able to control the disease and recover. So this has already been shown now by increasing and overwhelming experience that women tend to have a milder infection and recover better than male. But this was already evident by this analysis on the 4th of March when we finished the second screening in Bo. Now, this is the distribution of the positive individuals in the first and the second survey. And now if you look at children from 0 to 10, we have 217 individuals, and none of them was ever positive to the swab, in spite of the fact that some of them were sharing household with infected individual. I'll come to this in a moment. Then, as you see here, we have an increase in prevalence as the age increases. However, if you compare the number of positive on the first survey and the number of negative of the first survey, you clearly see that there is no difference in the ability to recover according to the age, though this could be biased by the fact that in this age range, there are more females than male. Can I have the next slide? Now, this was one of the most surprising findings that we observed when we start to look at individuals that were positive at the swab. On the first survey, we have 34 individuals which were positive were symptomatic, so they show symptoms like any of the combination of symptoms like fever, cough, fatigue, anosmia, and all other typical symptomatology of the COVID-19 infection. And some individuals were pre-symptomatic at the time of sampling, so at the time the swab got carried out didn't show any symptoms, but developed a disease later on. And then we have 29 individuals that at the time of the swab never show any symptoms and never fell ill. So this is equal to a percentage of about 39%. And combined, the two are more than 52% of individuals that at the time of the sampling didn't show any symptoms. Now, if I can have the next slide. Well, now this shows the PCR cycles that we obtain using two genes, the E gene and the RDP gene of the COVID-19 virus in asymptomatic, pre-symptomatic, and symptomatic individuals. And as you can see, we did not observe any dramatic difference. Now, these slides now show again, these are level of positivity that have been determined at different days. So in principle, we start the screening on the 22nd, and we concluded the second screening on the 4th of March, though positive individuals have been tested multiple times. And now this line connect individuals that have been tested several times. As you can see, you see that there is a decrease of viral load. Okay, if I next slide. These are, as I mentioned to you, we never observed children that were positive on the swab, and we have examined about 229 children on the first survey and 160 children on the second survey. Now, these children were all negative. However, 10 of them shared household with multiple individuals, and some which were severely ill. It never came positive. And the two of them, they had relatives and they had several contact with them before the quarantine was imposed to the city. And again, none of them. Can I have the next slide? Can I have the next slide? Okay. Now, we also calculated the probability of becoming infected when sharing household with infected individuals. We did this because on the second survey, we had 8 new cases. And as you can see, 6 of them were living, report living with an individual that had been infected. And as you can see, this gives a hold ratio of about 84. So in principle, if you share a household with an infected individual, you have 84 times the probability of being infected compared to individual that didn't live in the same situation. So if I can have the next slide. Now, we carried out a third survey in swab in INVO a month ago with the objective to look for seroprevalence. What we observed was the following. It's very interesting what we observed. Now, these are subjects which positive at least one swab. Now, they're 65 rather than 73 because we lost 8 individuals. Now, 50 of them were positive at the serology, which gives a percentage of 77% of them are positive. However, the most interesting thing is the following, that of the 2,172 individuals which were sampled on the third survey, which always were negative to the swab, 63 were at the positive serology, which makes a 2.9%. Now, if I can have the next slide. This is even more clear here. This gives the distribution by age of individuals which were positive on the with serology but negative at the swab. So now you can see this is the age group, and this is the positive serology, and this is percentage of positive serology and negative swab. And as you can see, there is a dramatic decrease by age, which shows that these individuals are biased toward younger age. Now, this is very interesting now to understand what has happened, because the fact that they were positive at the serology and negative at the swab, considering the fact that we never observed new cases of infection in Bo, the only explanation is that these individuals become infected, then were able to control the disease, then generate another wave of infection, then they were able to control the disease and eliminate up to the point that of the 22nd of February. At the 22nd of February, there were already probably 63 individuals which had already been infected and already been recovered from the disease. So if I can have the next slide. Now, this is a comparison between symptoms and seroconversion. Now, if you see, there is not much a difference in individuals which were positive at the swab, whether they were symptomatic or asymptomatic. There is a slight decrease in the level of antibody in those which were asymptomatic. But if you look now at the IgG titer in subjects that were positive serology but were negative to the swab, now you see a dramatic difference, which is statistically significant. Well, this means that these individuals, which were asymptomatic at the time before the 21st of February, they develop antibody, but apparently this antibody response is not lasting. So in principle, this means that if you in the antibody-mediated response that is induced in infected individual, asymptomatic individual is not lasting. Because if you compare this with this, it shows clearly that asymptomatic individual make antibody. However, if you look at the individual in which the infection had occurred much early, you don't see anymore this antibody, or you see much lower level. If I can have the next slide. Now, this is a model that recapitulates what has happened in Bo. This is a modified Bayesian sphere model, which takes into account the asymptomatic, the symptomatic, and the presymptomatic. And this model is intercepted by value of R0 between 2.1 and 2.4, and an infective window of about 4 days. Now, this is what happened in Bo. Now, this is what in blue, you see the effect of the lockdown, and this is the so-called unmitigated effect in terms of incidence. Now, this model tells us that if the local authority had not imposed a quarantine, and if the two surveys that have intercepted all positive individuals are not being carried out, in a matter of 14 days, probably 75% of the population of Bo would have been infected. Now, this is not surprising in terms of what now we observe in Lombardy, where the same measure had not been implemented. And I think I close here.
Thank you very much, Professor Crisanti. Now leave the word to Irene to introduce the next speaker.
Thank you very much, Luciano, and thank you, Professor Crisanti. A very interesting insight from the lesson from Bo municipality. I'd like now to introduce Massimo Cardillo, who will talk about the COVID-19 numbers in organ donation and transplantation. Thank you.
Thank you very much for this opportunity, and I'm very sorry because my webcam doesn't work. Anyway, I hope that this data will be clear. This is an opportunity for me to share some data on COVID-19 pandemic impact on donation and transplantation activity in Italy. The first slide, please. I have no conflict of interest. You can see in this first slide the weekly trend of donation and transplantation activity in Italy starting from January 2020. And as you can clearly see in the purple line, the number of transplants performed in the different weeks. And if you take a look on February 24, that was the day in which the situation of pandemic became initially clear in our country, you can see that the number of transplants performed that were about 100 in the last week before this date immediately dropped in the following 4 weeks, going to progressively to 75, 52, and 41, and 28 in the following 4 weeks. Then the number of transplants performed slowly recovered, as you can see, and in the last 3 weeks we have already came back to the pre-COVID situation. You can see in this slide also the weekly trend of donors reported and donors utilized, and also the number of family refusal to organ donation. You can see this particularly finding that we saw in the number of refusal to organ donation, because in the period of pandemic, on the peak of pandemic, we observed a reduction of the number of family refusal to organ donation, and this probably can be also the effect of an increased trust of the donor families toward the health of personnel in the intensive care units, because in that period doctors and nurses in ICUs were seen as heroes. So this probably can have been an effect on the number of consent to organ donation. The next slide, please. You can see in this slide the weekly trend of transplantation activity detailed by kind of organ transplanted. You can see that the decrease following the pandemic peak interested all kind of organs, so kidneys and livers and heart too. And in the next slide you can also see the number of lungs and pancreas transplanted. Next one, please. If we compare what has happened in Italy in the COVID-19 pandemic period with the situations in other European or extra-European countries, you can see that the drop in transplantation activity in Italy, if we compare the period going from February 28 to April 10, with a comparison to last year, you can see that the decrease in Italy was lower than that observed in United States. We had about a 40% decrease in Italy compared with about 50% to USA, or 75% in Spain and 90% in France. So we can say that the impact of the pandemic in Italy was some way lower than that other country around Europe and in the world had experienced. Next slide, please. Those are the main steps in COVID-19 pandemic in our country. The first problem that the National Transplant Center had to face in Italy was following the first identification of the first cases in north of the country, was the problem to guarantee the possibility to go on with organ donation and transplantation, trying to define safe pathways. So we decided very soon to start monitoring activity for all potential donors, and we decided very soon to perform in any potential donor the determination of the bronchoalveolar lavage for the research of the virus in the case of deceased donors, and in all living donors the SARS-CoV-2 testing by oropharyngeal or nasopharyngeal swab to be performed no more than 3 days prior to transplantation. We decided also very soon to start monitoring also for transplant recipient, and we decided to perform the nasopharyngeal swab on transplant recipient before transplantation, if symptomatic or with also with little symptoms, and at last also without any symptom. There have been also some other initiatives of the National Transplant Center with the recommendation to regional authorities to guarantee donation activity by keeping attention on brain damaged patient, because this was the most important point to be assured of. We recommended the region to avoid the downstaging of local coordinating units and to assure healthcare therapy to waitlisted patients by the identification of a devoted COVID-free pathway. We started also with the regional coordinators the monthly monitoring of COVID-free beds to assess the procurement potential, and we are also started the collection of data on ICU admitted acute brain damaged patient. We recommended also an homogeneous approach for communication with donor families, because the communication with donor families for the consent to organ donation was particularly difficult in the period of COVID pandemic. And also we suggested and recommended the organizational support to the transplant center, mostly in those centers in the north of the country that were not able to go on with the transplantation activity. In the last period, we also gave indication for the safe use of post-COVID donors, such as donors that had experienced a COVID-19 infection, recovering from it, and they can be also potential donor if an adequate period has passed coming from the recovery of infection. Next slide, please. We also started another data collection. We decided to collect the data on COVID-19 positive patients among transplanted patients by confronting two different registries, the main Italian registry of COVID-19 positive patient and the registry of transplanted patient from the year 2000 until 22 of March of this year. And as you can see, we collected the total number of COVID positive patients at March 22 that were 6,700 patients. Among them, 173 were transplanted with a functioning graft. So we found 173 positive patients among transplanted, 161 were transplanted from cadaveric donor and 12 from living donor. You can see that 20 patients were heart transplanted, 29 liver transplanted, 100 kidney transplanted, 8 lung transplanted, and 4 kidney pancreas transplanted. Next one, please. We also measured the prevalence of COVID-19 infection in transplanted recipient by kind of organ transplanted. We can see that the overall prevalence of positivity among transplanted patients was 0.39%, but this prevalence was higher in the case of heart and lung transplanted patients, respectively 0.6 and 0.73%, and lower in the case of liver and kidney transplanted patients, respectively 0.21% and 0.45%. Next slide, please. We also measured the outcome of this positive COVID-19 positive transplanted patient. We found an overall death rate that was 31%, with a mean age of that patient of 67 years. This death rate was higher when compared with that of the general population, that also had a higher mean age of 78 years. Comparing the death rate among the kind of transplant performed, you can see that the death rate was higher in the case of heart transplanted recipient, was 65%, and lower in the case of liver, lung, or kidney transplanted patient. We found also that in most cases, the transplanted patient that died had a long story of transplantation with several comorbidities. We have very few cases of recently transplanted patients. Only 4 out of 173 transplanted patients were transplanted in the year 2020. We are now going to update this information of those transplanted COVID-19 positive patients, and we are also updating the number until June, because those data have been stopped at the 22 of March with a follow-up until April the 6th. I think that this is the last slide, I think. So I thank you all for the attention, and I'm available for any request. Thank you very much.
Thank you very much, Professor Cardillo. I think in the interest of time, we leave all the questions in the end, and I leave now the floor to my co-chair, Luciano, to introduce the next speaker.
Thank you, Irene. It's my pleasure to introduce Umberto Maggiore, who will now drive us into the treatment. We heard a lot of data regarding epidemiology of the COVID, but now we need to hear something about treatment or clinical management, if any. I know that Umberto, who is speaking after, is always a little bit challenging, but we are running a little bit out of time, so please try to keep in the time slot. Thank you, Umberto.
Okay, thank you, Luciano. So my topic is COVID-19 treatment. What are we up to? I will address the issue of maintaining a free environment to perform transplantation activities, the policy of admission to the transplant unit, and the immunosuppressive treatment of transplant recipients with COVID-19. I will use as the backbone of my presentation this recent Italian survey and consensus, which was published on behalf of the Italian Society of Organ Transplantation, CITO, and the Italian Society of Nephrology, seen with the support of anesthesiologists, the infective disease specialist, and also the director, CNT, Dr. Cardillo. This was a Delphi consensus, meaning that there were some statements that were proposed to the responder, who had to answer yes or no, and the response rate was very high, close to 100% across 41 Italian transplant centers. I will not go through all the topics and all the statements, but I will try to focus on what in my view are the most important ones. First, the swab testing that has already been mentioned by Dr. Cardillo. Concerning the testing on deceased donor, we require deep airway swab testing. And the reason is the poor sensitivity of the nasal swabs. The implication of the poor sensitivity is simplified by this plot, in which you find on the x-axis the pretest probability of the donor being infected, the probability before knowing the result of the test. And on the y-axis you find the probability, what the probability becomes after the test is negative. In blue, you find the curve for the nasal swabs, and in green, the curve for the bronchoalveolar lavage swab. The arrow represents an example for a donor, for instance, which has 20% chance of being infected. If you have negative nasal swabs, then you draw a vertical line until you reach the curve, and you read the post-test probability on the y-axis. It becomes from 20 becomes 10%. It means that doesn't change that much. However, if we perform the bronchoalveolar lavage, then from 20%, the probability of after a negative test becomes 0%. That is basically certainty of being negative. Next. So for the live donors, ideally, we would like to have a swab test 24 hours before donation. And for concerning patients, that is transplant candidates, everybody should be screened by nasopharyngeal swab before proceeding to transplantation. But it is not only a problem of testing patients, donor and patients, also every doctor and nurse should consider themselves asymptomatic COVID-19 positive. As it has been shown by the experience of this surgeon, Matteo Ravaioli from Bologna, who, after being involved in several transplant operations, he developed a symptomatic infection the day after. That means that the day before, while operating, he was contagious. However, himself and his staff wore masks and used gloves for the contact with patients. And in fact, he didn't transmit infection to any patients. Next. The other issue is, apart from testing, to be sure that COVID-19 free pass can be ensured. Otherwise, the transplantation activity is not safe. This slide tells the story of the Parma Center. You can see on the left the Italian map representing with colors the percentage of death during the period of the epidemic, March-April, with respect to the same period of the previous year. Green means that numerically mortality was lower compared to the previous year. Red means that it was higher, and dark red means that it was 4 or 5 times higher. You can see that we in Parma, the arrow line, we were right in the middle of the storm, and in the picture in the center you can see the hospital of Parma, which has 1,000 beds. 700 of them were dedicated to COVID-19 patients. The transplant center was close to all these units. The radiology departments were surrounded by COVID-19 positive units. The intensive care unit beds were tripled, but only 8 were COVID-free. So we decided that we could not have a free path in our hospital, and we stopped the program until mid-May, when the storm was over and we could reestablish COVID-free areas all around our transplant center. The next one. To restart the activity, we had to completely reorganize our department. These slides summarize the new organization that allows us to start. A new organization that, in our view, must be able to face a new wave of the epidemic. It must be bulletproof, despite the fact that we have as a nephrology unit, be able to dialyze patients who may be positive to COVID-19. We must be able to admit patients to our unit that may or may not have infection. So the upper part of the slide shows the building, where the transplantation unit is located. For a transplant candidate to be admitted to the unit, the patient must be negative to a COVID-19 symptom checklist. Must have a negative swab, and the second swab is repeated upon admission. The lab examinations such as C-reactive protein, leaf count, and dimer are also performed, and we also currently are performing lung CT scan. On the second floor, which is completely COVID-free, besides transplant unit, we have an intensive care and nephrology unit, and hospital admission to this unit is allowed only for patients without clinical suspicion of having COVID-19 and patients that have a negative swab result. They are placed in single bedrooms until a second negative swab is performed. In contrast, on the first floor, we have a dedicated section for patients requiring dialysis, acute and chronic dialysis, who may be positive or suspicious or unknown cases, and each of them have a different shift. For what concern the admission of transplant recipients with potential complication, next slide. Then this is our approach for transplant recipients with clinical complication, with clinical problems. If the patients have some suspicions of having COVID-19, then he follows the path for the general population. That is the same for what concern hospital admission and discharge. If there is no suspicion of COVID-19, then the patient undergoes a swab test in a dedicated section of our outpatient clinic, and only if negative, it can be admitted to the unit where a second swab test is performed. So that is what are the strategies for maintaining a COVID-free environment. I have an additional 2 slides concerning the drug management of kidney transplant recipients with COVID-19. The first slide concerns the anti-rejection treatment. The management of anti-rejection treatment is a highly controversial issue in COVID-19 transplant recipients. However, most Italian centers would agree that in instances of patients with COVID-19 and severe pneumonia, immunosuppression should be strongly reduced. Continuing with steroids, usually at increased dosage, plus minus low dose calcineurin inhibitors. We also proposed as the CART working group within the ERA-DTA a very detailed approach to immunosuppression according to the degree of severity of the disease. There is a long table. In the lower part of the slides, it is reported only the top of this table, which concerns asymptomatic patients. According to this expert opinion, asymptomatic patients who are COVID-19 positive, their immunosuppression should not be changed unless they have risk factors such as having age 70 plus or having received in the last 6 months lymphodepleting agents. So the next, rather than relying on anti-rejection drugs to control for abnormal inflammation during COVID-19, this paper recommend to use anti-inflammatory drugs such as steroid pulses. This statement is currently supported by some evidence outside the transplantation literature. For instance, from trial in patients with RDS and other trials on other observational studies, on COVID-19 patients, showing that the use of intravenous steroids, especially in the early stages of disease after admission, for instance, 3 days of intravenous 1 milligram per kilo methylprednisolone, say 2 days after hospital admission, maximum 3 days, may improve the outcome of these patients. The other drug, which is very popular in Italy, is tocilizumab, an anti-IL-6 receptor drug. This has been used by many centers in COVID-19 patients. Currently, most centers, this drug is administered along with intravenous steroids. There are no many reports from Italy in kidney transplant recipients. Currently, there are 13 patients who have been published in the literature. 6 of them died. However, most of them were in very severe condition with a very poor prognosis. So overall, the use of tocilizumab gave so far mixed result, and we still need randomized clinical trial. So this is my last slide. I hope I was in time. We'll be happy to take questions.
Thank you, Umberto. Very, very nice presentation. So Irene, could you introduce the next?
In the interest of time, I thank also Umberto, and would like to introduce Professor Patrizia Burra, the COVID-19 in the waitlisted patient, the dropout.
Thank you very much for the nice introduction, dear Chairwoman. And dear colleagues, good evening, everybody. I would like really to thank ESOT for this kind invitation. It's a pleasure to be here and to contribute to this webinar. The next slide. Yes, please. The next. Okay. This is just a little bit of background related to the liver, since I will focus mainly on the liver transplantation being my field of interest. So let's say that the mechanism of the liver injury due to the COVID is still unclear, but probably it is related to the reaction, a sort of immunological reaction and severe inflammation due to the infection. If the liver damage is immunologically driven, we can in some way, let's say, speculate that the immunocompromised status of cirrhotic patient, a patient with liver cancer, but also the transplanted patient might be more protective than harmful. However, it is not clear yet if the risk of infection and the impact of the virus on the outcome are definitely worse in those patients. The next. So having said that, next slide. I would like to show you this study that was recently published in JHEP. This is based on a questionnaire that was distributed to 17 liver transplant centers around in the world, including Asia, America, and Europe, and in Europe, including Italy. And they proposed this quadripartite equipose score using 4 factors: recipient outcome, donor graft safety, waiting list mortality, which is my topic, and healthcare resources. The next. As you can see, next slide, when they wanted to, they need to use some published data in order to create the score. The score for the mortality wait list in Italy was the lowest in the world, at 5%, which is already a good news. The next. What was the background of this study? Definitely the need to balance the survival benefit of transplantation with the waitlist mortality, but also with the risk to donors in this setting of reduced national resources. So the aim was to create strategies in order to identify some policies to give priority for the transplant waiting list in response to the pandemic, but together with the ethical tension arising in this setting. So the authors propose a novel ethical framework which is applicable to liver transplantation in the context of limited national resources to guide ethical decision-making in liver transplant during pandemic. What did they find? The next slide. Overall, they found that more than 50% of the liver transplant centers around in the world reduced their transplant activity, and they employed the sickest first approach. What about Italy? Italy, during the time that the questionnaire was submitted, that was during March this year, Italy continues to grapple with one of the highest numbers of COVID cases per capita worldwide. And what they found in this study that the decrease in referrals was seen for deceased donors. UK decided to reduce the use of marginal graft to minimize strains on ICUs. In Asia, they reported the highest waiting list mortality, up to 20% in the majority of the Asian centers. And in fact, they move much more to the living donor liver transplantation more than they used to do in the past. Next slide. But overall, you see now here are the results about the study. So the pyramids show you the score. So the contraction of the pyramids will indicate the decrease of the score, suggesting a global need to decrease the transplant activity. If we look at Italy on the bottom, the data were recorded from the 1st, 12, and 24 of March. So with no doubt in Italy, the surge in disease burden returned a score of 0, reflecting the significantly reduced transplant activity. If you look at 3 countries, US, UK, and Germany, initially, they had the highest scores, that's the minimal ethical tension. Therefore, it means that they went on with the transplant activity, but then there was a rapid contraction due to the increased burden on healthcare resources, as you can see from the slide. The next one. If we look at our numbers, this is the numbers for CNT. We just listened to Massimo Cardillo, who is the head of CNT, and I have to thank Silvia Trapani, who provided me with this number. Of course, there are the numbers on all patients on the waiting list, but we'll focus on the liver, as I said. So we decided with Silvia to compare a cohort of the first month of epidemic from the 22nd of February to the 21st of March this year with exactly the same time last year. The patient on the waiting list last year were 1,099, of whom 157 were the new registrations during the month. If you look at the same situation this year, we had overall 1,124 patients on the waiting list, so a little bit higher than last year. But the patients that were with the new registration, the new entry during the month, were 132 meanings less than last year, with a decline by 60%. Next slide. But the good news are that when we look at the dropout from the waiting list, which was reporting 1.45% of the patient last year, this year was even less, 1.06, and deaths on the waiting list 0.9% last year during the month, and 0.6 this year, again confirmed that at least in the liver that was not affected very much by the COVID infection. Next slide. This is our situation in the liver transplant center in Padua, which mirrors exactly the situation, the national situation. We compare 3 months, February to March, March to April, April to May. And you see that the patient on the waiting list were a similar number, and the new registration increased month by month, 4 to 5 to 9. Transplantation the same, very few, only 2 the first month, then 7 and 8. Let's say that in our center, 8 to 10 is the average. We have 100, nearly, usually 100 transplantation per year. But again, the dropout from the waiting list, 4 patients in 3 months, which represent the average of 5%, which is exactly the average that we observed last year. We just saw the data of 2019 overall. In the 12 months is exactly 5.3% in our center, which confirmed that at least we didn't observe an increase in dropout from the waiting list in Padua. Next slide. What is the issue that we would like to raise a little bit? I think we have a problem, which is related to the referral to the transplant center. With Giacomo Germani, we launched a very simple tool 2.5 years ago. It's called e-referral. So the center that do not have the transplant activity, let's say the peripheral hospital in the region, Veneto region, but also outside, can send an email with the information about the patient, ask for the admission to our hospital. We give the result. We give the answer in 24 hours. That said, in 2 years, we accepted 188 patients in our unit. But when we look at the data, comparing 3 months, March to May this year with last year, we saw a declining by nearly 60% of the patients that we referred to us. Our policy during the pandemic was to consider to accept the patient for transfer only if they really need intervention at the transplant center, which was then reported actually in the ASLD guidelines recently published in Hepatology. So next slide. One of these patients that was one of the 13 patients referred during the COVID period is this one I'm reporting like a clinical case just to show you the daily life. We received a phone call on the 31st of March, and the peripheral hospital from a regional hospital asked us to transfer the patient. She was a 63 years old lady. She had a decompensation of alcohol-related cirrhosis with hepatocellular carcinoma. She had hepatorenal syndrome, And they asked us to evaluate the patient for liver transplantation. As a standard, they had already performed the testing for the COVID, and she was negative. So we accepted and we transferred the patient within 24 hours, as I said. Next slide. So on the 8th of April, this is the situation. She was critically ill in terms of the liver dysfunction. And however, from the COVID-19, she had no fever, no dyspnea, no diarrhea. Oxygen saturation was fine. Chest X-ray, as you can see, was negative, apart from the enormous ascites. However, next slide. When we routinely repeated the testing for the COVID, she was positive. So the next slide, following the policy in our hospital, we moved the patient to the dedicated ward, the COVID dedicated ward in our hospital, where she was, she stayed for nearly 8 days. During those days, she was still asymptomatic. She didn't need any antiviral therapy. She repeated the COVID testing, and the third one was negative, so back to our unit. When she came back, we decided to perform a more deeper research, search for COVID infection with the endotracheal aspirate, and which was negative. Then we performed the serology and demonstrated that she was IgG positive. And in summary, we were in front of a cirrhotic patient with decompensation, hepatocellular carcinoma, who had experienced COVID infection without symptoms and with spontaneous clearance of the virus. So the issue here was really to propose that patient to be listed for liver transplantation. So we needed really to discuss with the infectivologist, with the anesthetist, intensivist, with the surgeons, of course. And the next slide, at the end, we took the decision to list the patient the 6th of May. 2 weeks later, she was transplanted. From the point of view of the surgery, that was not easy at all. Since it was an extension of the portal vein thrombosis. So the MELD didn't reflect the severity of the disease absolutely due to the hepatocellular carcinoma plus ascites plus renal dysfunction. And the patient was and is actually very sarcopenic. I saw the patient last week. This clinical condition is improving very slowly. She's still in the hospital, but she's alive. So I would like to conclude the next slide by reporting, let's say, 3 main messages. The first one, I would say that in Italy, at least based on the data that we have and the experience that we have, I would say that the COVID epidemic was being in some way contained in terms of the impact in general, in the registration, the waiting list. In terms of dropout and mortality, again, the epidemic did not affect the dropout from the waiting list and the mortality on the national waiting list. However, this is the point that I raised before. There is, I believe, a realistic risk of diminished referral of critically ill patients to the transplant centers. And the problem is that we are not able to have any information on how many and which cases would have needed to be managed in a highly specialized center. Thank you very much for your attention.
Thank you very much, Professor Burra. And I am very sorry, but we are quite late, and unfortunately there is no more time for opening to the floor for Q&A. I would like to thank all of our exceptional panelists that have given an exceptional insight on what is the real impact of COVID-19, particularly in Italy, but I assume that this general principles could be applied worldwide. And I would like also to encourage all of our attendees who have sent their question to post the same on our COVID-19 forum. These questions have already been answered in the previous webinars. There is a dedicated thread, and you can just post your question, and we'll take care of addressing this to our panelists. I would like also to invite you to stay tuned for the next ESOT webinar on June 29th, Managing Transplant Programs During COVID-19 Pandemic Part 3. And finally, on July 13th, the last of our series, the impact of COVID-19 on liver transplant patients. And this is an ESOT, ESL, and ILTS joint project. Many thanks, everyone, and thanks also to my co-chair, Luciano Potena.
Thank you, Irene, and thank you to everybody who attended, and very much to the speakers. Thank you very much. Bye.
Thank you.